Hello and welcome back to the Spine Pod. I am so excited to talk about this episode.
We'll talk about a surgeon that's doing work that is not being done anywhere else.
Yes.
We were able to sit down with Dr. Ahilan Sivaganesan at Thomas Jefferson University in Philadelphia, and he is pushing the paradigm of health economics. I mean, the conversation that we have, you can't find in a textbook somewhere, you can't find in a video. It's really, really impressive, the work that he's doing. And I think we're going to start to see a paradigm shift on the topics that he is talking about. And I really haven't heard about him anywhere else.
I agree. He loves to go by Siva. Yeah. And Siva makes me feel better about healthcare in general, knowing that he's out there working on this.
It's tough not to. I mean, a guy that's so early on in his practice and to be doing the things that he's doing, the work that he's going to do is absolutely going to change what we see in spine care. And he is a fascinating individual, been to very prestigious universities, right? And very well trained. And I don't think it hurts to have two parents that are math PhDs.
No, definitely helps, especially with what we're talking about in this episode.
Absolutely.
I just feel smarter after my conversation with him.
I think for patients especially, you're going to hear about not just what devices are offered or what procedures are offered, but actually how the care model works and why things operate the way that they do. Why does it take me so long to get from A to B? Or why do these costs matter? Or why does one thing get offered, not another thing? Those are all concepts that Siva talks about. And it's fascinating to hear kind of a little bit behind the veil of how that works into spine care.
Absolutely. So a lot of really great, dense information. Because of that, we've put this into two parts.
Yep.
Because it's just too good, right?
There's so much material.
Too good.
Yeah, there's so much material. And I think the first part is great the second part, you can't just listen to it. We actually work through one of his research projects, one of his publications that talks about health economics and the cost factors that go into healthcare decisions and spine care specifically. And it's one that you have to watch, so it makes sense to break it into two
there's
parts.
Visuals that we'll be including in on that second part. So definitely keep an eye out for that and check it out on Spotify or YouTube, where we do have the video podcast.
Yeah, and we're just so lucky to sit down with him. So we sit down with him at Thomas Jefferson, and he's actually making a move down to a new practice in Naples, which we'll talk a little bit about in the episode. But if you see this late, he's going to be at a new practice down in Naples, so which will be really exciting. I think he's going to continue to push a lot of this work forward.
Absolutely. So let's just get into this one. Enjoy this episode with Siva.
Dr. Ahilan Sivaganesan, thank you so much for sitting down with us today.
Oh, thanks for having me.
Hey, we appreciate you taking us into your hometown, your territory here. And,
we're in Philly.
Yeah. This is fantastic. Hey, well, we are gonna explore a lot of topics today, and there's a lot of stuff that we want to jump into. The side of medicine that you research and that you're driving forward is something that a lot of people do not talk about on a day-to-day basis, or a lot of people don't want to talk about on a day-to-day basis, right?
Elephant in the room.
That's right.
Absolutely.
Yeah.
But I think one of the biggest components about like a part of our healthcare system that needs to change, right?
Yeah.
So when we talk about the economics of healthcare, when we talk about, not only the procedures that are being done, but how are they being reimbursed and what's the patient journey through the hospital?
Right.
These are all concepts and proponents that need to be pushed forward, and for a multitude of reasons haven't been for a long time, right? And there's a lot of those things that I want to jump into today. But before we get into that, I want people to know who we're sitting down with here today. So we know you as Siva, but everybody else, you come from a very you went Baylor College of Medicine, then you spent time at Vandy for residency, and then you made your way to HSS for your fellowship, which is obviously the number one orthopedic practice around. So from that background, and then really you spent a large portion of your time and have continued to on, this economics of healthcare. And, there's this concept that we're going to talk about a lot today that I want to bring up right off the bat, and it's the time-driven activity-based costing.
It's a mouthful. It's a mouthful.
But we're going to be hearing about it today.
Yeah.
And, I want to start off with a little bit of your background.
Sure.
Tell us about, where you came from, what got you into medicine, and kind of what brought you to where we are today sitting at this table.
As a little kid, how did you know that you wanted to be a surgeon?
Exactly.
Give it all to us.
Yeah. Well, thanks for having me again. So my name's a mouthful. It's Ahilan Sivaganesan. So thankfully, I think I go by Siva. Yes, I was born in Dallas of all places. We moved to Cincinnati a month after I was born. I grew up in Cincinnati. And both my parents actually have math PhDs. So the joke that math is in the bloodstream there. And so I went to Rice for undergrad because I had this romanticized notion that I wanted to go back to Texas and reclaim my Texan roots.
Absolutely.
I didn't know you were from Texas.
Oh, yeah.
Fellow Texans here. I knew I liked you.
Yes. And, but I was born in Dallas, but because we moved so quickly, I felt like it was a bit of like am I really Texan or is it only in name? So I was like, I need to go back and make this real. So I did undergrad at Rice.
How was that heat?
Oh my God, the summers.
It's like peanut butter, right? Like trying to walk through.
It's like getting slapped in the face when you walk outside in the morning in the summer, just by the thickness of the humidity.
Yeah.
And so I majored in statistics at Rice, and that probably ended up being one of the better decisions I made on the professional side of things, because at the time people were like, all right, you're going to med school, like statistics, that's kind of weird. But it ended up being this really neat skill set of sort of like applied mathematics that is sort of the language by which all research is done, right? It's like the common foundational currency for a lot of research. And so that ended up being a really neat thing that I was able to apply different stages of my medical career later, which we'll get into. Rice was great. And then I stuck around at Baylor College of Medicine for med school. And I actually wanted to go into pediatrics initially.
No way.
Did you?
Yeah. So my family's from Sri Lanka originally. And there's been a lot of difficulties there. There's actually a genocide that affected my nationality and my people there. And so for the longest time, I wanted to go back and be a pediatrician and help rebuild and help take care of kids there. But because of the political turmoil and the difficulties to travel back safely, it didn't really make sense. And so then I was faced with the decision of, okay, if in fact I can't go back on a long-term basis, I got to find something that I'm passionate about, with this being my home base, being the US. And I would basically go on these different rotations, and I felt like if I was looking at the clock during my med school rotation over and over again, I knew it wasn't for me, right? And that, but if I felt like time was flying fast, then that was that's a good sign. And I was always interested in the brain and the nervous system, so I thought about neurology. And it's a great field, but just the sort of experience I had in med school, I felt like there was a lot of thinking and not as much doing. And I'm sure there are a lot of neurologists that will take issue with that. So it was just how my experience in med school was skewed, where I felt like it was a lot more about the thought process and diagnosis and less action-oriented. That's changed now with things like thrombectomies for stroke that neurologists are doing and all sorts of stuff. So I was a bit at a loss for a while. And then as stories go, I was studying late in our med school library with one of my friends, and we hadn't eaten dinner yet. And we're like, what should we do for dinner? And there was a notice on the med school bulletin board for a free Thai food info session, neurosurgery interest group. And it was that night. It was 7 o'clock, 7:15 in the library. There's going to be this info session on neurosurgery. So I was like, let's go to that and get some pad Thai for free,
Very, very student of you.
Yeah, right. So I go there, and that's the first time I kind of got exposed to neurosurgery. And I was like, oh, this is a little more of the doing side of people who are interested in neurosciences and neuro conditions. So I started shadowing some of the neurosurgeons there. And that's how I got into neurosurgery. So it was definitely a roundabout path. Yeah.
Fascinating. Well, it's so funny that you tell these stories. I got into grad school the same way, right? One of my professors I was like, hey, this guy's coming onto campus. I'm supposed to be hosting him. I'm sick as a dog. Can you just land him? Ended up at grad school, right? So I was actually enrolled at medical school at the time met with this guy. And it was just funny how those life-changing things happen. We sat down with Dr. Pat probably a month ago. And he said he was trying to get out of the heat in Oklahoma. And so that's how he got his job in the lab. He's like, I just don't want to work outside. So he started working on dog spine models.
Spines. That's how he learned about it.
Oh my gosh.
He's like, there was nothing. So then he just was in the library just reading about dog spines.
And that's how he got into 50 years of biomechanics. Like
he became the world expert.
Yes. How could the craziness of those stories,
oh my gosh.
But I think it shows you end up where you're meant to be when you have those kinds of click moments.
Right. Not to be cliche, but it's like that Steve Jobs line from that commencement sheet, but you can't connect the dots always moving forward, but looking back, you can connect the dots.
Yeah.
You know? Yeah.
So that's fascinating. And one of the parts that I want to talk about here, and you talked about how you got into neurosurgery. I want to take a little step back because it's something that's close to us. Your time at Vandy,
sure.
And I think probably one of the people that had a big impact on you. Obviously, he's had a big impact on us as well. Probably mentor, colleague, friend, Dr. Clint Devin.
Yes. No. Thanks for bringing him up. So I got to Vanderbilt for my neurosurgery residency, and I thought I was going to do, stroke care, something intracranial, which is sort of, I think, what most people who end up going into neurosurgery think about when they first get started. And Clint Devin, I think, embodies this notion that oftentimes what you do in life, you decide to do based on the people that you're surrounded by and what a certain field or a certain career direction represents in terms of the personalities of the people. And, I remember going to some research meeting that he was involved in, and I knew who he was, but I wasn't necessarily there to meet him. And I made some comments at the meeting. He made some comments. And after the meeting, he's like, hey, come by my office. Let's chat. And he just had this charisma and this sort of grounded, real talk, sort of no BS energy around him that was just gravitating, or that I gravitated to. And so he said, hey, this is what kind of research I'm working on, love to have you participate. And he started out as sort of like a research mentor. And he and his partner, Matt McGirt, who's now in Charlotte, had sort of built probably the top of class, one of the earliest ever prospective outcomes registries for spine. So I started doing research with him, and the stats background definitely helped. And it was sort of a team that we created to do all this good work. But he started as a research mentor, and then I had the real privilege of spending 2 years of dedicated clinical training time with him, which was unique, given that I was a neurosurgery resident. He was an orthopedic spine surgeon. Another credit to just the kind of person he was. It's not normal.
Yep.
Usually people get territorial, and they don't want to sort of give too much to the other side. He wasn't that way. He was the kind of person where it's like if he was good at something or he had identified something of value, he couldn't help but share it with the people that he cared about. And that's true for clinical pearls, technical pearls in the operating room, research ideas, personal life, everything. And so he went from research mentor to teacher, like clinical teacher. And then I probably used this line a few times, and I hope it's not like overdone. And then I left Vanderbilt, went to fellowship, and then the relationship morphed where he became more of like a life mentor. And then after I started in practice, I felt like he became like a big brother and a friend. And that sort of evolution of a relationship is so rare that I don't know how to put fully into words like what he meant to me personally and professionally. And like my wife met him once for maybe 2 minutes, like years ago when we were dating. And she, even though she never got to know him, like she sees him as this like incredible like figure like in my life, just from the stories I tell and the way I talk about him. And the same thing with my parents, like my parents never had a chance to meet him, but he holds this like special place in our hearts. And I'm just one of many who have that experience with him. So yeah.
I was going to say, he radiates something special, right? Yeah. And it's funny because his legacy lives on right now, and it will continue to live on for a long, long time, right? And the research things that he's done, he built the practice now that Dr. Slaticky has picked up the flag and moved on with, and covers this huge swath of Colorado and Wyoming. but he introduced us to RedCap too, right? So we're a very data-driven, company, and everything that we do is based on that same thing, right? What do the outcomes look like? What are we trying to measure? Why do these things matter?
Absolutely.
And he was the one that put us onto that, right? So a lot of our success and things that we've been able to do with research, and you've been involved in that, right?
Absolutely.
Wouldn't be around without him, but his legacy will continue to move on. But the thing that I was going to say is, we traveled all around. So when we did this clinical study, we traveled all around, right? You bring up his name and everyone has a story. Everyone lights up, right? The way that you just had that story, everybody has that about Clint. And it's amazing because it's easy to have those one-off interactions, right? When you're like, I turned on for the day, I really showed up. He was on it all the time, and everybody told the same story about him, you know?
Right.
But what a lasting legacy. And I know he has a big place in your heart, and he's meant a lot to us as well.
Absolutely.
So, But no, that's fantastic. So, beyond that, you get into this. I'm curious, was he one of the people that kind of spurred that interest in this, health economics, research-based, like what, I know obviously your background was in the statistical, analysis realm, but what spurred that for you to say, like, I'm really going to spear, because it's not like you do this thing on the side, right? You spearhead this and you're pushing it forward for essentially across the board in spine. And I'm curious what spearheaded that
thanks for the question. So, I came at it initially from this idea of anyone that has a background in statistics loves the idea of having a data set they can play with. So that was how it started. But then I was shocked to find out when I was in like the middle of my residency that spine surgery, as an example, is a field where we don't regularly measure the outcomes of what we do. And in most fields, I'm talking about outside healthcare, whatever you do in life, there's this essential sort of aspect of it where you measure so that you can improve. And the fact that that wasn't being done regularly in the spine world was shocking. And that even the definition of what success is wasn't really established was exciting, because now it's like, oh, okay, so that's a little concerning that this hasn't been happening all this time. But on the flip side, we can help define what that success looks like. How do we make sense of all these metrics that we're finally starting to collect and translate into something that is digestible to patients, to employers, to payers, and everything? But Clint and his partner, Matt McGirt, I think really, amongst others in this sort of small sort of vanguard, really sort of dropped the gauntlet, or threw down the gauntlet and said, we need to measure things that are important to patients, and then start to understand how to pick treatment options or to pick the patients that are ideal for certain treatments based on the analytics we can do on these metrics. So that was just like it was almost a no-brainer for me to be able to jump in and help do some of the early work around, for example, like if my family member needed to get a TLIF, and I'm in clinic with them talking to a surgeon, the kind of questions that I would ask, knowing how the sausage is made, is like, all right, what do you think the chance is that she's going to be able to return to work in 6 months, or that she's going to get a pseudoarthrosis, or that she's going to have to go to rehab? I know now, being in practice for a few years, that we sort of give these sort of vague answers like 80% or 15%, or it's not data driven at all. And to be able, for a surgeon to be able to say, hey, look, we have this predictive model. Here's an iPad app. We've plugged in the specific information about your unique characteristics and the specific surgery that we're thinking about for you and your particular diagnosis. And here are some personalized probabilities of both positive and negative outcomes for you. You tell us which of these outcomes on either side, positive or negative, are most meaningful and important to you. And then we can have a shared decision-making process about whether this is the right thing for you or not. I think we all want that in any aspect of care. And the fact that that didn't exist and that we could help build some of the models to power some of that stuff was just fun. It was like a fun thing to be a part of. And so that's kind of how I got into sort of the outcomes side of things initially.
Well, and it touches so many things, right? It pushes the standard of care forward, potentially, because we'll actually look at how are we doing what do these results look like?
Right.
Where we've been a bit blinded to it.
Yes.
Other than, subjectively, we can say, for example, you see patients in fusion, like I have a sister, brother, aunt that's had a hard time.
Yes.
So that's kind of like all but to actually have hard data. But also the type of conversation you can have with a patient in such a stressful and scary moment to be able to see, here's real numbers that I can relate to.
Yes.
That would be huge as a patient because spine surgery is scary. It's a scary moment. I mean, you deal with that day to day when you talk to patients. It's a very, people will wait years to actually do something out of fear of having that surgery.
Yeah, absolutely.
So I think that just the impact that makes across the board is huge.
Right. No, thanks. I totally agree. Yeah.
And it's interesting too, when we talked with Dr. Kechatarian, he talked about this concept that I really loved, and it was probability versus possibility of outcome metrics, right? And the truth of the matter is, most of what we have is subjective.
Yeah.
Right? I mean, for the most part, to your point, like how many patients are getting reoperations in 5 years? Well, it's about, how about 10 years?
Right.
Well, it's about, right? We haven't been driven, and for a variety of different reasons, to push for answers on that, right?
Yeah.
And have objective data that we can make essentially measures upon and say, here's what success looks like, right? And I'm curious what you think, because I think we see it in some other specialties, not across the board, but there has been wide adoption in other orthopedic industries, right? We have total joint replacement for knees. We have total joint replacement for hips and shoulders and ankles. And if you went in and then, essentially you blew out your knee, went to the doc, and they said, we're going to fuse you, you just laugh and walk out, right?
Say, absolutely not.
And why is spine a lagging field in that metric? And I know there's, biomechanic components and there's technological components, but from your opinion, being someone that's so in depth in the data, why is spine the lagging category in that?
Yeah. So I think there's a few reasons. I think one is definitely true that, like you said, like the lumbar motion segment, even though there are 3 major joints there, that it's not, I do think it's true that it's not fair or right, and it's overly simplistic to sort of say, well, like all joints are the same, and if we're replacing other joints and not fusing them anymore, like we should obviously be doing that for the spine. I think that's a bit of like a lazy argument, I think. But the fact remains that there are opportunities for motion preservation, and they are not given as much clinical attention or R&D effort as the fusion. And I think there's one reason that's a little bit controversial, which we're going to get into, I think more and more today and in the future, is the reimbursement structure, which is that, spinal fusions keep the lights on for spine practices and help keep the lights on for hospitals. It's one of the most well-reimbursed procedures for a surgeon, and it's one of the most well-reimbursed DRG codes for hospitals. And there is this notion of a fusion industrial complex that I think Armin talks about and others talks about, other people talk about as well. And I'm not saying here, and I think we're all on the same page, there are patients for which a fusion is the right option, and it can be life-changing. I do plenty of fusion operations, and I feel that way. But in terms of pushing the field forward and being open-minded and being open to things like MODIS or a facet replacement or an anterior lumbar disc replacement, fusion is something that currently is oftentimes a easier procedure to do for the surgeon and pays more than the motion preserving alternatives, which was really surprising to me when I came out into the practice, because in training you don't really see the sort of the reimbursement side of things. And so, as a simple example, an ACDF, anterior cervical fusion versus a cervical disc replacement. Let's take a patient that's a candidate for both. An ACDF is relatively forgiving surgery to for the surgical technical standpoint compared to cervical disc replacement. Armin talks about that all the time. And yet you get paid significantly less to do a disc replacement. Same thing is true for a posterior cervical laminoplasty versus a posterior cervical decompression and fusion. Everybody talks about the laminoplasty procedure being a little finicky. You have to be really gentle with the instruments and with the plates, and a lot more thoughtful about your soft tissue dissection. With a posterior cervical fusion, you don't have to be as thoughtful about those things. And it's oftentimes in certain hands quicker to do the fusion operation, and it pays significantly more. So those are just like two examples where the fusion procedure pays more and is a little bit easier to do. And it's behavioral economics 101. Like I'm not saying that, myself or anyone else that is doing a fusion is, doing the wrong thing for the patient, but we all follow incentives, and it's incumbent upon physicians, policymakers, payers to set the arena in a way that incentivizes best outcomes at lowest cost. And that is not what we have today.
Yeah. Do you think it's a bit of groupthink of like, it's been this way for so long? And when you come out into practice, it's like, well, there's a lot to be processing when you're going into practice. And like, this is just how it is.
Right.
And it's just a little bit of like the snowball continues to go. Unless you sit in a situation like you, where you stopped and said, hey, I want to actually look at overall what are the results? What are we looking at?
Right.
Where you're seeing these gaps in the breaks in the system.
Yeah. Right.
You're looking at it through, care for patient.
Yeah.
Right. Like value-based care for a patient.
Absolutely.
Right.
Absolutely.
It's so interesting to me. Like, it's very confusing in my simple mind to say like something that takes longer is harder and is going to at least give you potentially the same results, if not better, that you're not going to get paid more for that.
Right.
I have to imagine there is some political aspect of that, or just too many hands maybe of like what an insurance company, that I don't quite understand.
Yeah, I think part of it is historical in that there are these things called these RUC committees, where, CMS, or Center for Medicare, Medicaid Services, runs Medicare and Medicaid. They sort of set the ground rules, and then the private payers follow suit. And there are these regular occurrences where they will sort of kind of do focus groups with specialist physicians to figure out how much work is required to do a certain type of procedure. And that's what ends up deciding how much, the RVU or sort of work values associated with certain procedure codes. And historically, the fusion codes got high valuations for that. Rightfully so. Achieving a good fusion is not a trivial thing.
Sure.
And the codes used to be, we call unbundled. So it'd be like, okay, if you're going to do a T-lift, there's a code
you get to get all of these different.
A code for the instrumentation. There's a code for the arthrodesis. There's a code for the cage placement. But then the motion preserving procedures are newer. And CMS realized that when you have 4 codes for a procedure and you have to pay for each code, things add up pretty quickly. It
becomes a treasure box a little bit.
Right. And then where if it's one code for a cervical disc replacement or a lumbar disc replacement or a laminoplasty, it's easier to ratchet down how much the payers are paying when it's just one code. And I think that's one thing that has affected disc replacement, is not just the fact that the code for disc replacement is less than the code for arthrodesis, but that there's 5 codes for doing a fusion instead of 1. But it's still shocking to me, because if you talk to policymakers or people that are in those circles, they'll say that like the government doesn't really believe that lumbar fusions work. To the other extreme, like I don't think any of us are saying they don't work. It's just that you need to make sure you're doing it on the right patient at the right time and make sure there's not a non-fusion alternative that might be better, right? They don't actually believe that lumbar fusions work. And one of their missions, I think everyone agrees, is to limit the amount of lumbar fusions so that they don't have to pay as much, and so they keep costs down. And yet the reimbursements for motion preserving alternatives are less.
Yeah. And fusion is so high.
Yeah. And that's the thing that is still not sure how that square is getting circled. Yeah.
No, it's like such conflicting ideas and like perspectives.
Yeah.
And it's like, how are we here?
Yeah.
We're like in the upside down.
Yes, totally. It's Stranger Things. Totally. Yeah.
But even when you look at non-instrumented procedures, right, where you can do something less, hopefully get them down the road and not have to worry about some of those alternatives. But the problem is, to your point, it doesn't matter what, if they don't think it's a good procedure, the reimbursement is backwards. And I don't think anybody's doing it nefariously, right? The truth of the matter is, it's some component of you, right? I could do a 2-level fusion, or I could do 5.
Yeah.
I'm gonna get reimbursed more for 5, right?
Yeah, you can make an argument for it.
Exactly,
Preventing
right?
something in the future, whatever it
That's
is.
exactly it. Well, I'm gonna have to do this next one in a couple of years anyways.
Yep.
I'm just gonna take care of that now.
It's
That
the
is-
game board you're on, right? It's
Absolutely.
like you have to continue to play the game in front of you to survive and give care.
Yeah, totally.
And I think you bring this up too, is that happens at the detriment of the patient.
Totally.
Right?
Yep.
So it is almost skewed against patient outcomes in some regard, right? And again, I don't think it's for nefarious purposes. It's just the way it has been for a long time. And I'm curious, there's something that you have talked about, you've done a lot of work on this. And I love the concept of moving from fee for service to more of this bundled code, or essentially going for diagnoses instead of the actual procedure. Right? Reimbursing for diagnoses. And I want you to talk about a little bit because I think it's a fantastic topic.
So I think for people who don't know, like the label that's most often applied to the dominant reimbursement model for physicians or any care providers in the US is fee for service, which means that you do a activity and you get paid for it. The more complex the activity, or the more of that activity you do, the more you get paid. And so that works in certain situations and in certain, in other fields outside of healthcare. Like if you own a car dealership, the more cars you sell, the more money you make. That's fine. But the question becomes in healthcare is like, what are we trying to optimize for, right? It's not that the healthcare system is best that does the most things, right? Like it's not that if you were to rank every country's healthcare system, that you would say the number one country is the healthcare system that's the busiest, that's doing the most things, right?
It's almost the opposite,
totally.
right?
It's actually, and that the joke about is it a sick care system versus a healthcare system is that what you want is patients to be healthy and for outcomes to be good at the lowest cost possible, because we're all paying into this system. And so that's where the term value comes across, of course, and it's like a totally overused term. But really, value is outcomes achieved per dollar spent.
I've got your quote on my page. And I was like, he's going to beat me to it. He's going to beat me to it.
Outcomes achieved per dollar spent. So, and then the question we have to ask ourselves is the current healthcare system in our country, the marketplace, if you will, competing on value? And we're not competing on value. We're competing on all sorts of other things, but not value, except for there are like pockets where that exists. But in the sort of dominant aspect of all American healthcare, we're not competing on value. And so then you ask the question, like, what would that look like? And this is why the cost analytics stuff, I think that we started to do is important. And I'll just give you an example, which is take a patient that has a cervical radiculopathy, they have arm pain shooting down their left arm. They've tried all the conservative things. They've tried injections, physical therapy. MRI shows they have a disc herniation at C5-6, and their quality of life is really affected. They're not working anymore, and they're ready to get something done surgical, and they're a good surgical candidate. And they go to see a surgeon, Surgeon X, and the surgeon recommends an ACDF, anterior cervical discectomy and fusion, a perfectly reasonable operation for this problem. But say it turns out that this patient is in that subset that would also be a candidate for what's called a foraminotomy, which essentially is a clean-out procedure. It's a decompression that doesn't involve putting any implants in. Sure. Not every patient with a cervical radiculopathy is a candidate, but some are. And say this patient happens to be one of those patients. And they go to Surgeon Y. And Surgeon Y says, hey, look, I think we can get you better with this foraminotomy. You don't have to put any metal. We don't have to put any metal in your neck. It doesn't mean it's your last operation, but I think it's the least invasive thing for you. And then let's fast forward in these two parallel universes where this patient got an ACDF in one universe and you got the foraminotomy in the other universe. And we compare the two. Let's say the outcomes were the same. Two good operations with the right indications. But let's look at the costs, right? And what I mean by costs is costs to the patient, costs to the hospital, and costs to the payer. On all three, the hospital costs are less because they didn't have to put any implants in. The payment to the payer is less, and therefore whatever out-of-pocket expense to the patient is inevitably going to be less. And because the recovery time is less, they might go back to work faster, which means the costs on society and the cost to the employer is less. So I think for the right indication, the foraminotomy is the better option for everyone involved, right? But if you don't measure the costs in addition to the outcomes together, you wouldn't appreciate the fact that the foraminotomy is better. In fact, if you're looking at something like RVUs, relative value units, or revenue for the hospital, the ACDF looks better. And that's why I think measuring value is important, which means you have to measure the outcomes and you have to measure the costs. And it's not enough. In some places, people will take costs and as a proxy for cost, they'll look at how much the insurance company paid the hospital. But that gets into all the unique, what are the negotiated rates that this hospital has with that employer? And there's all these other confounders. But if you get down to brass tacks with what did it actually cost to execute this episode of care and merge that with the outcomes, now you're looking at value. And if you're competing on value, a lot of these weird incentives and sort of odd observations that we're making, I think would fall by the wayside.
And there's something that I want to go through, and I'm going to try and do it at the end. I truthfully haven't done it before because we don't have people that have done as much research and have as much work done on this. I would like to walk through some of your examples on this because some of the graphs that you have made on this, it is outstanding to take a look at it. And, the point that you talk about too, it's going to be interesting to see how the dynamic changes when systems start to become the payer. What we're starting to see, right?
Yeah, like the vertically integrated system.
Exactly, right? Yeah. Because now you take those costs into consideration where you didn't before.
Right.
So that 3,000 versus 7,500, there is a makeup there. Totally. And to your point, there's no benefit to the hospital right now. There's no benefit to the surgeon to go with that other route. So with all things equal on outcomes, you're going to go the opposite route, right? Right. Which is a really fascinating. And so I have a quote from you that I want to read really quickly. And no, it's great. It's on the point that you just made. It's on the point that you just made. It's about costs. And you said, we can't reduce costs if we don't know our true costs. We can't make value maximizing treatment decisions if we don't know the true cost implications of various choices. Charges aren't the same as costs. Reimbursements aren't the same as costs. Collections aren't the same as costs. Surgeons need access and ownership of the data and insights that truly matter. Otherwise, everyone, and patients most of all, will suffer. And I think that is, when you read that, it kind of summarizes up everything that you talked about, we talk about these aspects. And when you go to a hospital and say, what are your costs associated with this? They can tell you, what they're paying out. They can tell you reimbursement rates. They can tell you device costs, disposable costs, right? The actual care that it takes, the time-driven, what you talk about, the time-driven, activity-based. That is what is missing, right? Because all those components are important, but they still don't tell the picture, right? This implant component, that might be the best way of care in some situations, right? This most expensive model, if the outcomes are the best, then we should be pushing for that, right?
Totally.
But in a lot of cases, and you show this, and this is why I want to go through your research, is that you show that the most expensive way doesn't turn a better outcome in a lot of situations,
absolutely.
right? So that's something I just wanted to highlight.
Yeah, no, thanks. Yeah. I mean, just to define time-driven activity-based costing and why I think it's important. So this is something that is commonly done outside of healthcare. You kind of can't really run a business in most aspects of life without knowing your own true costs, right? Whether it's a lemonade stand or whatever it is. And so Michael Porter at Harvard Business School and Robert Kaplan put out a seminal Harvard Business Review piece many years ago now called How to Solve the Cost Crisis. And these ideas come from that, where they say, if you don't measure your true costs, you can't start to improve them or measure value and do anything else you want to do. And so what they say is, okay, take an episode of care, whether it's a clinic visit, a surgery, or an entire, 90-day episode, and create a process map where you essentially shadow the patient through every step in that whole care process and observe all the personnel and material resources that are being applied to that patient in every step. So if you take a clinic visit, it would be, okay, patient walks in the door, they talk to the front desk receptionist. Okay, that was 3 minutes. Then they get called into the room and a nurse works with them for 5 minutes. And then the doctor comes in for 10 minutes. And And then at the end, they do a checkout. They're talking to the receptionist again. So that's personnel. But then there's also the material resources, right? Like, are you renting this building? What's the utilities for that? You have an X-ray machine in the back. How much did that cost? So there's all these material and personnel resources. If you can dial down and say, okay, that was 3 minutes with the front desk receptionist. We're paying that receptionist X dollars a year. Boil that down to how much they're getting paid per minute, times 3 minutes. You do that for every personnel, and you do that for every material resource, and you add all that up, you get a true internal cost of executing that care episode. So the challenge with that problem, with this issue, is that it's hard to scale it.
Yeah.
Right? Like, if you want to do it for 5 patients, maybe you hire a medical student or like a research nurse, had to give them a clipboard, shadow this person around, hope they're not annoyed, get their consent first, and they're sort of like, how much do you get paid to do that? Like, it's very weird, right?
Yeah.
And I think that's one of the reasons why it hasn't been deployed at scale in healthcare. So my passion over the last 2 years has been to say, can we take this TDABC, time-driven activity-based costing methodology, and automate it as a software layer on top of the typical electronic medical records, and then pull in information from the medical record, and also pull in sort of institution or practice-specific information that varies from place to place, and then put that together and create essentially a prospective cost registry that you can then couple with the prospective outcomes registries that we all have now. Because now you have, for a given patient that had a given procedure or a given care episode, we have the outcomes that matter to that patient, and we have the true cost of care. You merge that together. Now you're tracking value in real time. And then you can start to ask questions about what is the right treatment for the right patient at the right time. So that's kind of the background for that.
That's fascinating.
Oh, thanks. Yeah.
It's crazy that we don't do it, right? It does sound very difficult. My question to you is, it also ruffles a lot of feathers.
Yeah.
This is how we've done it, and we've always done it this way. And there's a lot of people who benefit off of the way that we do it. What kind of pushback do you see, having these conversations or trying to do that? I'm really curious.
Yeah, it's definitely, I joke sometimes, like, healthcare, in particular surgical care, thrives on sort of this like veil of like opaqueness, right? Where sometimes patients don't necessarily know all the details of things. Physicians don't necessarily know what each other are doing. APP, like all the stakeholders, there's a lot of
silos.
A lot of silos.
Yeah.
And I have to thank my partners so I'm at Thomas Jefferson right now, and I wouldn't have been able to do this work without my partners in the neurosurgery practice, in the department, supporting it. And saying, you know what, like, this is kind of part of our mission. It's good research. It's good for patients. And if there are opportunities for us to improve as a part of this, we want to do it.
Yeah.
And that's not trivial at all. So I have to thank, Robert Rosenwasser, my chairman, my division chief, Jim Harrop, and all my partners in our division, Srinivas Prasad, Josh Heller, Jack Jallo, who were game for this. And so transparency is a funny thing. So we took as a proof of concept ACDFs, one level ACDF, and said, let's look at the true intra-op cost of care for this procedure across every surgeon in our division and across every hospital in the 18-hospital Jefferson network, and see what we see. And there was incredible variation just on the cost alone for something that we all think of as like kind of a homogeneous thing. I'm not talking about T10 to pelvis fusions or this kind of thing where it's like, well, there's incredible variation. It's a one-level surgery, cervical spine, maybe the closest thing on the sort of implant side of the spine to something that is a little bit like nicely packaged up. And there was like 3x, 4x variations in intra-op costs in one health system. What we then did, I think, which I'm proud of, and this is based off of a New England Journal article where this was done for total joints many years ago. We said, okay, it's not enough to just identify variation. Now we want to dig down and figure out what are the drivers of this variation. So we split up the total cost into supply cost and personnel, split up the personnel down to like every single person that comes into that operating room. The circulating nurse, was there a fellow on the case? Was it a RN F first assist, a radiation tech? How many minutes is the radiation tech spending in that operating room? What's the dollars per minute for that radiation tech times the number of minutes they were there? To figure out what are the explanations for these differences in cost? And there were some really interesting. Some surgeons are just faster than others, and that's one thing. Some surgeons use less expensive implants. Some surgeons use less expensive biologics. Some surgeons do it the same way every time. So the staff knows I only need to open these 3 trays.
You get efficiency.
The other surgeons, it's like you don't know what's going to happen.
Yeah.
And the rep doesn't want to get in trouble. The circulating nurse doesn't want to get in trouble. They don't want to get yelled at. So they open everything.
Yeah.
And that means the sterilization costs are increased. And we're capturing that as well. And some surgeons don't teach in an academic environment, right? Others teach more. If you teach more, that affects the time.
Yeah.
So all these things we were able to drill down, and then that creates opportunities, right? Where you say, okay, you know what? What if we were to standardize these 4 or 5 sort of low-hanging fruit and then bring down our costs? It's good for the hospital because they're getting paid the same amount for that DRG, but if the cost comes down, their margin goes up. But the big elephant in the room here is the cheapest care is no care.
Yeah.
Right? Like maybe you throw in, something that you picked up on the side of the street into someone's spine and call it an interbody cage, and it's going to be free. And that's really horrible for the patient, right? And so it's not enough to just track the costs. You have to track the outcomes as well. That's why we launched the Prospective Outcomes Registry at Jefferson as well. Because, a classic example is you take a big, large surgery and Surgeon X will say, I want gel foam, I want Fibrillar, I want all these expensive thrombotic agents to control bleeding in the surgery. And the hospital committee will come and say, hey, doc, we really don't want you to do this stuff anymore. It's eating into our margins. None of the other people are using this. The surgeon will say, well, my reoperation rate for hematoma evacuation is less. That's why I do it. Nobody has the ability to test that claim in traditional situations. But if you take a given choice that leads to variation in cost in the operating room, and you can track the specific outcome that is relevant to that choice. So in this case, let's look at the probability of reoperation for hematoma takebacks for all the surgeons, for a given type of procedure, for a given diagnosis, and then evaluate the fact that, okay, Surgeon X is using something that costs $10,000, but his odds of a reoperation for a hematoma takeback are 30% less than everyone else. Well, what's the cost of a takeback? It's $100,000. You know what? Maybe we should all be using this stuff because in that situation, it's actually saving money in the long term.
Yeah.
Or if it's a flip scenario where a surgeon says, I need to use this really fancy expandable dual expanding cage because that's going to lead to better fusion outcomes. It's worth it. Trust me, because I'm going to get fewer pseudoarthroses in the future. Well, let's track the outcomes and track the costs over 6 months. And if it turns out that fewer patients are needing reoperations because of that short-term investment you made into a more expensive implant, maybe we should all be doing that. So that's I think the key is to have the outcomes and the cost. And without it, it's just gonna be hatchet jobs all day long, and it's just gonna be less care and cheaper care, but not necessarily better care.
And I think the biggest part that I love about your work is the applicability of the work that you actually do, right? So we especially in research, and I see this a lot, I'm sure you see this a lot, right? We take all these, high level concepts and, this idea is great and how can we do these things? But the truth of the matter is, how can we make objective decisions based on that data, right? And that's essentially what you're doing. It's not just saying, oh, well, this person, the research, part of the research is this surgeon uses $10,000 worth of biologics, right? But the contrary to that is, what does that mean for the patient? What does that mean for the hospital? What does that mean for us on a care basis? And should we be or should we not be making that decision?
Right, totally.
And that's the biggest part.
Yeah,
I think that's the biggest part on what you can make objective decisions based on the data that you're feeding into the system.
I think if there were a overarching theme to what gets me excited about this stuff, it's the idea that I think we all deserve, because we're all patients at some point, we have family members that are patients, is to feel like we're going to get the right treatment at the right time. And sometimes that's no treatment. Sometimes that's a big treatment. Sometimes something in the middle. Sometimes it's a fusion. Sometimes it's a motion preserving device. Sometimes it's not surgery at all. And, the kind of work that we're talking about right now, when I first started doing it, I was like, honestly, I was thinking to myself, okay, so if I can help a hospital improve their profit margin because we're doing the same surgery less expensively, I guess that's great. But that doesn't really get you up in the morning, you know? Okay, sure. What if I own the hospital or I owned a surgery center? Yeah, then there's that's more money in my wallet. Okay, that's great. But is that really what this is all about? And that's when I realized that the more you can zoom out on this sort of outcomes and cost tracking, the more powerful it becomes. And that's where I think there can be a real contribution, and things like motion preservation actually get highlighted. So let's say, instead of just saying we want to reduce costs for ACDFs, you made the point about condition-based thinking. Let's say, and this is going to happen, because right now, there's like a primer, people talk about bundled payments, and the definition of a bundled payment is whether it's an employer or the government or Blue Cross, they come and say, all right, T-lifts, 1 level lumbar fusion, this is your lump sum payment to the hospital, to a practice. It's up to you to decide how to divvy up your dollars and execute this care for this T-lift procedure. If your costs exceed that predetermined lump sum payment that we gave you, you're going to lose money, tough luck. If you come under, you keep a piece of that savings, right? That's the idea behind the bundled payment. What it does is it reduces waste within the care episode because it forces all the stakeholders to get lean. So maybe we should use that less expensive implant, but it doesn't necessarily reduce overutilization of unnecessary procedures, right? You still want more bundles. You still want to do more T-lifts. You just want to do it in the least expensive way. And the stakeholders have realized this. So what's coming now is condition-based bundle payments, not procedure-based bundle payments, where they're going to say, okay, lumbar stenosis or lumbar spondylolisthesis, when you have a slipped vertebra and you have nerve pinching associated with it, here's your lump sum payment for that. You figure out how to make that work, whether it's physical therapy, pain interventions, mental health, opioid weaning, because maybe you just wean the patient off of opioids, and maybe their pain doesn't get completely gone, but it gets just better enough that they can do whatever they need to do, or surgery. When you get to condition-based bundled payments, suddenly now the foraminotomy looks pretty good compared to the ACDF, as long as the patient gets better.
Yeah.
Right? Because that might be an outpatient procedure that the patient leaves in 2 hours, no implants. And now if you start assessing surgeons or practices on a condition, that ACDF, loving surgeon that does it for every patient, who looks really good to the hospital in the status quo, because the DRGs for the fusions are coming in and life is good, versus that surgeon that's like, you know what, when it's the right opportunity, I'm going to do a foraminotomy. Maybe that's 30% of the time for a unilateral radiculopathy, whatever the rate is. That surgeon's going to look really good in a condition-based bundled payment system because they're getting the same outcomes at a much lower cost. And the hospital's going to love him, him or her, the practice is going to love it. And so when that happens, practice patterns, I think, are going to change.
And think of the incentive alignment on that as well, right? If you're a patient coming in, you know that the best interest is at heart because it is based on treating and promoting a better outcome, right? Not just the procedure itself, right?
Right, exactly.
And it's funny because on your website too, you offer the quote unquote least amount of surgery that is necessary to achieve a durable solution for patients. You often believe that there is no role for surgery whatsoever. Not many surgeons are putting that out there on their website, right?
Yeah.
And
that's a rare thing to see online.
Right. To your point, right? When you go to this bundled case where you're treating the condition, you're probably going to send more patients home with non-operative care or injections or some other function that is not cutting on the first stage, right?
Well, it's just putting the patient first.
Totally.
It's absolutely putting the patient first, which is all you hope for. Sitting, in that room.
Yeah, no, totally. I mean, I make a joke sometimes when you give talks, you have to say your disclosures, right? And like conflicts of interest and, consulting for some company. But it's like the most fundamental conflict of interest you have as a surgeon is that you get paid to do surgery, right? And fundamentally, like any like if my relative had to go in to get a consultation for a hip replacement, I hope that surgeon is the kind of person that is only going to offer hip replacement if it were the same thing if it were their mom.
Yeah.
But sometimes you just decide, well, who's in my network and what's the distance to drive to that person? And what's their availability? And then you hope for the best. We shouldn't have to rely on the good graces of the physicians only to make this work. The system should be designed in a way that makes it a no-brainer for everyone to function in that way. And I think condition-based bundle payments is one step in that direction. But it also means that you can't just measure the costs in the operating room. And that's another thing I realized was that, OR costs is fine, but maybe we should be measuring the costs for the whole hospital stay, or maybe we should be measuring the costs for the whole care episode from the moment the patient got diagnosed to hopefully the time when that symptom got resolved, right? And that actually brought up some really, scary and also interesting things because we got into this exercise of what I call journey mapping, where I essentially took a patient that had all their care within Jefferson. And said, when was this patient first diagnosed with lumbar radiculopathy or lumbar stenosis? It was in May of 2021 by a Jefferson primary care doctor. And then when did things sort of settle out and sort of the story come to a close? Well, it was like 2.5 years later. They got a lumbar fusion with my senior partner, Jim Harrop, did great, went back to work. Life is good, right? That was like a 2.5-year process. So I actually had a couple medical students basically go through the chart and recreate the story of that patient's care every step of the way. So it's like, they went to their primary care doctor, they got an MRI, the MRI showed these concerning findings, they went back to the primary care doctor said, hey, look, I think you should see a spine surgeon. Went to see a spine surgeon. The spine surgeon said, hey, you've got some problems here, but it's a little too soon. Go back to the primary care doctor. Primary care doctor then said, I guess that was the wrong person. Let me send this patient to send you to pain management. Was in pain management for maybe 6 months, getting injections. Went back to the primary care doctor, got a new MRI, went to see physiatry, went back to the surgeon and said, let's get new imaging. So it was like a 2.5-year process with a lot of I played video games growing up. It's like side quests, where it's like you're off here. I don't know. I guess this is what I'm supposed to do. And so it's 2.5 years. And I asked these the medical students to, in whatever way you think is appropriate, create a visualization of this journey. And they both did it in different ways. And then we combined them and we created this journey map where we kind of color-coded the different kind of visits and then had time associated with it. And it literally looked like a hornet's nest, the maze that it was. And I was like, this is one of the biggest problems in healthcare. It's not just about what implant type to use when you do a certain type of surgery, or is this biologic better than that? That stuff is important, but it's more the upstream thing about how do you shepherd a patient through the journey for a given problem that they have so they get the best outcome the fastest. And by fastest, that also oftentimes means least expensively, right? And so you can do time-driven activity-based costing, not just for the OR. You can do it for the whole patient journey, right? And if you do that, you'll start to notice, that was like a side quest that didn't matter. Maybe we cut that out. How can we design this system in a way that gets them to the right place at the right time? So that's what I'm really excited about now is tracking costs at every step of a patient journey and their outcomes. Because if condition-based bundle payments, if and when they come, it's not going to be the practices and the systems that have the best doctors that are necessarily going to win the day. It's going to be the systems that arrange their care model in a way so that care journey looks as much as possible like a straight line.
Yeah.
And not like a zigzag abstract painting. And because then they're going to be getting the best outcomes at the least dollars spent, and they're going to look really good on that condition-based bundle. And patients also will be like, you know what? The doctors here are great, but what I really love is that I have peace of mind that when I go in and they tell me to go here next, that there's logic behind this, there's science behind it, and that I'm going to get to the end of this in the most sane way possible. Yeah.
All right, we're back.
We are back.
We're back. Just finished up part 1 with Siva.
such a good episode, and part 2 is going to be a very visual episode. So that's why we want to split these up. And if you only listen to part 1, for sure go and watch part 2, because we actually get to dive into the research that he's doing and get in the weeds and see some of the graphs that he makes. And I think that's kind of where some of the substance is.
Yeah, absolutely. So thanks for watching this first part, and we'll see you in part 2.